Hello, everybody. Welcome. Thank you so much for joining this Target webinar today. I can't see any of you, but I know there are quite a few people subscribed. I'm Emily Cooper. I'm a research program manager in the Primary Care and Interventions Unit within UK Health Security Agency. I'll be chairing the session today, and we'll have our speakers and panelists introduce themselves in a minute. Today, we have an invited guest speaker. Conor Jamieson is going to share a presentation he's developed on the evidence behind recommendations for RTI management in children. You can find all of our previous webinars on the Target Toolkit, which is on the RCGP website, and the recordings and slides from this webinar will be uploaded there in a few weeks' time. Following some introductions, our speaker will present for around 40 to 45 minutes, and then we'll aim to have 15 minutes at the end of the session dedicated to questions and answers with our panelists. A few housekeeping points before we begin. The chat function is disabled during the presentation, but you can use the Q&A function to ask questions to our speaker or to our panelists. Tick the box in the function if you'd like to keep your questions anonymous, and we'll answer as many questions as possible during the allocated time. We'll also publish a Q&A printout after this webinar when we put the webinar online. So if your question didn't get answered, hopefully we'll be able to provide a response to it at that time. Panelists, as I said, can answers through the webinar, and we'll save some of the discussion questions, some of the questions for discussion at the end. As mentioned, a recording of this webinar will be uploaded to the Toolkit, and very important bit, at the end of the webinar, you'll see a brief survey link from the RCGP. If you could fill that out, it's really useful for us as we develop future webinars and other resources for Target. Could you go to the next slide, please? So first, I'd just like to say and acknowledge the Target and RCGP team who work on Target resources and on this webinar. A big thank you to them for all the work that goes into producing these series like this. Please, next slide. And I'd like to take a moment to have our speakers and panelists introduce themselves. So I'd ask them to take their camera and put it on. And Conor, we'll go ahead and start with you.
Thanks, Emily. So my name is Conor Jamieson. I'm the Regional Antimicrobial Stewardship Lead for NHS England for the Midlands region, and I'm a hospital antibiotic pharmacist by background.
Alicia?
Hi everyone, I'm a consultant in paediatric infectious diseases and immunology at the Evelina London Children's Hospital. This is part of Guy's and St Thomas's NHS Foundation Trust, and I am a consultant epidemiologist at the UK Health Security Agency. My team is responsible for the surveillance of AMR and prescribing. I'm very excited to be here and really nice to see so many of you joining us this evening.
Thank you. Graham?
Hello, I'm Graham Deuce. I'm a GP in Cheshire, and also for quite some time I've been a ICB, or before that CCG prescribing lead, which does involve particularly areas around antimicrobial stewardship overall.
Thanks, Graham. And Sanjay?
Evening everyone, I'm Sanjay Patel. I'm a paediatric infectious diseases consultant in Southampton, and I'm also the National Clinical Advisor for Paediatric AMS at NHS England.
Thanks, Sanjay. And just to say, unfortunately, our community pharmacy colleague couldn't join us today, but if there are any specific questions to that role, please do post them and we'll try to respond to them in the Q&A summary that we publish later on. All right, without further ado, Conor, I'll hand over to you.
Lovely. Thank you very much, Emily. I'm just trying to move my slides. So good evening, everyone, and thanks for dialing in. So I'm very grateful to RCGP and the Target team for the opportunity to present on this topic to you today. So, I'm just going to start a timer, excuse me, just to make sure I keep as best as possible to time. So I'm going to be talking about the evidence for managing respiratory primary care. And really what I'm going to cover is what drives healthcare consultations and what drives clinicians to prescribe antibiotics or supply antibiotics. What does the data look like? Very, very high level of what the data looks like nationally. Is there a way that we can address prescribing antimicrobial prescribing in primary care? Is it possible to reduce it? What would that bring any benefits to workload? Talk a bit about the harms and benefits that antibiotics bring in the context of respiratory tract infections. Very briefly mention 2 important studies about respiratory tract infections in children, and then moving on to some sort of practical tips, perhaps, of how to manage respiratory tract infections and different prescribing strategies, approaches. So a very high level overview of what we're going to cover in the next 45 minutes or so. So thinking first of what drives healthcare consultations and antibiotic prescribing. So when I was trying to pull this talk together, I was trying to get a handle on what's the sort of the burden, or what's the volume of prescribing for respiratory tract infection in children in primary care. And there's lots of bits of information out in the literature, and I've just pulled out some data here. But what the literature suggests, and you're probably aware of this as well, is that children tend to have quite a high consultation rate for respiratory tract infection, higher than that of adults, and that those who get labelled as having a upper respiratory tract infection or a chest infection tend to get antibiotics. In some studies, there's a cohort study here of almost 40% of the children in a study of around about 8,000 children in primary care getting antibiotics for chest infection. And when you scale those numbers up, it's something around about 2 million prescriptions per annum, with drug and healthcare professional time costs of around about £30 million a year. But there are some sort of wider societal impacts as well that aren't so easily quantifiable. So the medicalization of what's often a self-limiting illness within the family or wider social networks. So the preschool groups or the school gate discussions of when somebody needs antibiotics or not. And this chart on the right just shows you recently published data looking at the sort of respiratory tract infection consultation rate for children aged 0 to 5 in England over the last 5 or 6 years. So it's running from 2016, almost the last 10 years to 2023. And you can see that it's obviously very seasonal, and there are peaks depending on the severity of what's circulating in winter. But what the data suggests is that, in some winters, you can expect between 8 and 10% of your registered paediatric population to be consulting for respiratory tract infection. So quite a burden of consultations in primary care. And what is driving that? Well, so from the sort of caregiver perspective, the parent and carer perspective, when they seek a healthcare consultation, what the social science tells us, the qualitative research tells us, is they want a proper health check. They feel that there may be a health threat to their child, and they lack the confidence to distinguish that threat, whether it's to distinguish between a relatively minor self-limiting illness into something that's more serious. But they absolutely believe that you as the professionals can do that. And during a consultation, they also want to know what they should look out for, when to seek help. So what are the red flags? They might not describe it as that, obviously, but what should they be concerned about, and what should they do should those situations arise? And really practical steps or practical advice on managing and caring for their child. And again, the qualitative evidence says that parents don't generally seek antibiotics, but they are anxious. And we know that as in this patient population, younger children, there's relatively low rates of pathology compared to your older patient cohort, but that the rate of parental anxiety is obviously high, and that's driving consultation behaviour. And then flipping the coin a little bit, so looking at it from the clinician's perspective, the healthcare professional's perspective, what qualitative research tells us of why they prescribe antibiotics. So first of all, there's a belief that bacterial infections require treatment with antibiotics. And obviously that can't be entirely true, because the human race has been around for a lot longer than antibiotics have been available for us to treat people with. There is this perception that antibiotics will speed up recovery from illness and also prevent complications arising. And I've circled that because I'm going to come back to that later. There's a very real, very genuine, and a very understandable medical legal aspect to all of this. Of course, you've got a young patient population who can't necessarily advocate for themselves, can't necessarily provide a history. You're relying on caregivers for that. There's genuine concern that these patients might deteriorate rapidly, and that as a result, a healthcare professional who doesn't prescribe antibiotics or doesn't recognize that risk could feel very culpable if that child was to become deteriorate or become septic. There's also a widespread belief, which you see in the published literature, that parents are seeking antibiotics. Now, that isn't always necessarily true, as we've seen from the previous slide. It's anxiety that's driving the consultation. But we know that in primary care, there's enormous workload pressures. You're managing risk on continuous basis, really, and that some healthcare, these consultations, sometimes it's easier to prescribe antibiotics and it feels like the path of least resistance rather than having what might be a challenging conversation with a parent or carer who's expecting and demanding antibiotics. So just to pause those there for a moment and just think, well, what does prescribing look like in England for children? It isn't all specific for respiratory tract infection, obviously, but the evidence suggests that the bulk of prescribing is for respiratory tract infection. So you'll be aware that we have a metric in the NHS Oversight Framework for Primary Care, which is looking at the portion of children aged 0 to 9 who've been prescribed one or more antibiotics in the previous 12 months. And what you can see with the top bar chart here is the variation across the 7 regions of NHS England. So you can see the Midlands, my region in the middle there, 29.9, so 30% of children in the last year have had an antibiotic. The variation you see, Southwest region lowest at 22.8, and in east of England currently 33.1. So, an absolute difference of around about 10 percentage points, but a relative difference of about 45% between the lowest and the highest prescribing. So quite a degree of variation. And when you look at the line graph below that, this is divided up into age bands. So you've got the 0 to 4 age band, which is the blue line, then the 5 to 9 and a 10 to 14. There's a couple of things, take home messages here. So first of all, you can see the dip during the pandemic. You can see around about, so this data runs from October 2019 up to the most recent data set. So you can see the dip of the pandemic. You can see a spike due to the Group A strep outbreak in winter 2022-23. And because this is 12-month rolling data, that data persists before it drops off. But the take-home message really is when you look at the most recent data for July 2025, the prescribing of antibiotics to children aged 0 to 4 is higher even in summer 2025 than at winter 2019. So you can see we've increased by quite a reasonable proportion the amount of antibiotics we're prescribing for children. And you can also see that at the 0 to 4 age group receives between 2 and 3 times as many antibiotics as the other 2 age bands in that graph. And if you just pick one financial year, this is data from the SPOWER report from a couple of years ago, which is an annual stock take of all of our prescribing data, all of our healthcare associated infection data, resistance data, plus lots of other good stuff. A really interesting report. Just in one annual snapshot, 5.3 million prescriptions for children aged 0 to 14. Half of them went to children aged 0 to 4. And of that 0 to 4 cohort, almost half of them got an antibiotic within that, at least one antibiotic within that financial year. So a real high level of population exposure. But of course, this was the year we had that Group A strep issue. So is there something we can do about this? And would it be safe to try and reduce antibiotic prescribing in primary care for children? And would that have benefits to GP workload? So first of all, do we have data to say what this prescribing is for? And this data is relatively old. It's from about 2013 to 2015. But what it shows is for these conditions on the left-hand side, so acute cough, bronchitis, sore throat, otitis media, viral cause usually, you can see that the real-world data of how many times patients get prescribed antibiotics for those conditions, in a lot of cases, it's almost 9 out of 10 patients are getting a prescription for that, and that is way higher than what the expert opinion would suggest, given the knowledge of the natural history of the illness, the likelihood of complications, and so on. So real-world data is saying that we tend to overprescribe for these conditions, and one of the challenges that we know that from other qualitative research that prescribing tends to lead to reconsultation. So this is a recently published systematic review and meta-analysis, and overall it's showing that while the quality of the strength of the evidence isn't fully statistically significant, it's pointing to the fact, all the studies point to the fact that if you prescribe antibiotics, people tend to reconsult in the future. And when you go into a bit more granular detail on some of these studies, you can see that prescribing leads to increases in reconsulting behavior, quite significant, between 40% more likely to return within 6 weeks if you get antibiotics for sore throat, and almost 70% more likely to come back again in the future. And in another study, people who get antibiotics for lower respiratory tract infection more than twice as likely to come back in the year following that consultation where they get antibiotics. So prescribing, all of the evidence is pointing to prescribing driving consultation behavior by medicalizing these conditions. So is it safe to do something about it? Could we tackle that? Well, this is a really interesting study using English primary care data. So absolutely, fantastic quality research in primary care in England. So this is real world data that's relevant to your patient population. So this is it was a mixed method study, but I'm just pulling out the cohort study that did, almost 670,000 patients across 700 and something GP practices. And what this study was intending to do was, what's the likelihood of sepsis arising following a primary care consultation for either urinary tract infection, skin or soft tissue infection, or respiratory tract infection? And then what was the impact of antibiotic prescribing on the probability of sepsis? So, and what you can see from the chart on the right-hand side is that the probability of sepsis increases as our patients age, as we might expect, more comorbid, less reserved, weaker immune systems, whatever it might be. The probability of sepsis is also higher for people who present with a urinary tract infection, followed then by skin and soft tissue. And the lowest probability in this study is of this triad is respiratory tract infections. So when you look at the patient population between people who are between less than 25 years old, the probability of sepsis following a respiratory tract consultation, a primary care consultation for a respiratory tract infection, is less than 1 in 10,000. Now, that probability is reduced in half by prescribing antibiotics, but that probability is so low, really, to begin with, that antibiotics arguably aren't really making much difference to that probability of sepsis. And when you look at the numbers needed to treat for the younger patient cohort, so for thinking of children aged 0 to 4 here, you'd need to write almost 30,000 antibiotic prescriptions to prevent 1 case of sepsis arising from a consultation for respiratory tract infection. This is another really nice study published just last year. Again, English primary care data. This is 1,471 GP practices, and they stratified the practices by their rate of prescribing for respiratory tract infection. They did some pre-stratification of the GP practices to adjust for age, sex, and comorbidities of their population first, and then stratified them by the respiratory tract infection prescribing rate. And they're looking to see, was there a difference between, and they divided them into 5 groups, so quintiles, between the highest prescribing practice right down to the lowest prescribing practice. And they looked to see what was the likelihood of admission to hospital for pneumonia within 6 days of that indexed consultation for respiratory tract infection. So they had data on 9 million patients, 35 million respiratory tract infections. And what they found was there was no difference, no statistically significant difference in the rate of hospitalization for pneumonia for the highest prescribing practice and the lowest prescribing practice. So this green shaded line here that you can see is the odds for hospitalization. Now, if you look at the red line, you'll see that is the odds ratio for reconsultation. So inconveniently for my argument, the odds of reconsultation were higher in the lowest prescribing practices compared to the highest prescribing practices. And for children, it was around about a 13% increase in odds. I'm going to come back to that, but we'll pick that up later on in the talk. Okay, but it's just worth acknowledging that there. So moving on then to thinking about the sort of harms and the benefits of antibiotics. So you won't be surprised to know that antibiotic prescribing, whether it's inappropriate or appropriate, leads to resistance. It's just the fact. Resistance follows consumption. But what's striking about this study, and this is a sort of a meta-analysis of a number of studies as well, looking at different antibiotic combination, different antibiotics, the impact on the susceptibility of pathogens following receipt of antibiotics. And that impact persists. So it's measurable anything up to 2 weeks after getting amoxicillin, for example. You'll have a less susceptible organism from your respiratory flora. But also that resistance persists for anything up to 12 months. So we're really surprising a length of time. So almost a 2.4-fold increase in odds of having a less susceptible or resistant organism in your respiratory flora for up to a year after receiving antibiotics. So there is some individual patient resistance, and that's relevant when we think of repeat antibiotic prescriptions going, which I'll talk a bit more about later on. And antibiotics are medicines, just like any other medicines, and they do cause harm. And that's not a surprise to anyone, of course, but we tend to believe that those harms are relatively mild and self-limiting. So this study was looking at the impact of short versus longer course antibiotic therapy and looking at the risk, what proportion of patients develop an adverse drug event, which was around about 20% in this study of 71 different trials comparing different courses in both adults and children in hospital and in community settings. Every extra day of antibiotic therapy was associated with an increased odds, a 4% increase in odds of developing an adverse drug reaction, and a 3% increased odds of developing antimicrobial resistance. And of course, this is comparing, say, 7 days plus versus 3 or 5 day antibiotic courses. So if we know that every extra day is harmful, when we consider whether the antibiotics were needed in the first place, then we can see that even a 3 or 5 day course is obviously going to be more potentially harmful than no antibiotic course at all. And you might be, if I was to ask you what antibiotic harms you think you might get following antibiotic, you'd tell me probably, upset stomach, diarrhea, maybe a skin rash. And obviously most of those are minor and self-limiting. You could have the potential for anaphylaxis or a toxic skin reaction, which are obviously much, much more severe, but those tend to be very rare. But what if there were some sort of longer term harms that we haven't really recognized before that may be altogether more consequential in a different way? So this is a complicated slide, and I apologize at this time of the evening to present you with lots of hazard ratios, incident rate ratios and stuff, but this is summarizing 3 different studies that looking at the impact of early antibiotic exposure, as in early on in life within the first 2 years, and then associations with risks of developing asthma, food allergies, obesity, intellectual disability, as described in one study. And they're quite heterogeneous, these studies. So there's one from the States, there's a really big study from the UK with 1 million patients, and there's an Icelandic study. And they're all pointing to increased risks or increased hazards, I guess, of things like asthma and obesity. Now, there'll be lots of the speculation there is that disrupting the microbiome early on in life is, which we know is increasingly beginning to understand is important for immune function and various things like that. Disrupting that with antibiotics at an early stage in life may well have longer term consequences that we haven't recognized before. Now, these are association studies. They are not, they're correlation, not causation, but they're all pointing in this direction. And if we think of, reason why a child in England might become asthmatic or become obese, these are knotty, thorny public health problems, whether they be air quality, parental smoking, lack of access to healthy food, difficult public health problems to solve. But what if we could have an impact on those public health challenges by just rethinking how we approach antibiotic prescribing for respiratory tract infection to children? So let's make the case for the benefit of antibiotics and how good they are at preventing risk of complications. So first of all, it's just worth, I always find it useful to remind myself of what's the natural history of respiratory tract infections in children. So this slide is a systematic review of a number of different trials and observational studies, and the different colored lines on the graphs are for different studies. And I guess the take-home message here is that these things tend to linger. They don't disappear quickly for all patients. And as a rough rule of thumb, you might be looking at between 5, 7 or longer days for somebody's symptoms for whatever the respiratory tract infection is to dissipate. And a helpful way to think of it maybe is, instead of giving the message that you're probably going to feel better in a couple of days, is it's going to take at least 7 days for 9 out of 10 children to feel better with this condition. And that might be a more helpful way to express it to caregivers. So if you've done target sessions before, you'll recognize this slide, which I've shamelessly lifted. But all these conditions here on the left-hand side, so otitis media, sore throat, sinusitis, bronchitis, have a strong viral component to them. Antibiotics deliver very little symptomatic benefit for those, obviously, because if there's a viral infection, they deliver no benefit whatsoever. And what you can really measure in is, for a condition that has a natural history that you can measure in a week to 3 weeks for, say, acute cough and bronchitis, antibiotics really only deliver benefit measured in hours to a day at most. And what's interesting is the number needed to treat for one patient to benefit for otitis media, as an example, is 18, but you only need to treat 9 to harm one patient. So again, that just helps, I suppose, think when we're thinking of the risk-benefit ratio of antibiotics. But what about complications? is prescribing antibiotics protective of nasty complications further down the line? So again, another really nice study by Professor Gulliford as well, English primary care. So this is 4.5 million patients who were in English GP, general practices. So they stratified the general practices first on the rate of prescribing for respiratory tract infection. So same methodology, highest down to the lowest group. They then looked to see for patients who'd received an antibiotic for respiratory tract infection. They looked in their notes for up to 10 years following that index consultation to see was there a code that indicated a more serious complication. So pneumonia, peritonsillar abscess, mastocytitis, empyema, and so on. And what they found was that there was no statistically significant difference between the highest prescribing practices and the lowest prescribing practices for several of these. So mastocytitis, intracranial abscess, meningitis, empyema. These things are so rare following a respiratory tract infection that prescribing antibiotics to prevent them is, you're not making that huge a difference to the odds of the likelihood of those things happening. There is a difference with peritonsillar abscess and pneumonia, and they calculated in their study that if you reduce prescribing by 10% for respiratory tract infection in a practice of around about 7,000 patients, you could expect to see one extra case of peritonsillar abscess a year, and a decade, and one extra case of pneumonia a year. Now, that's not to make light of these conditions, and that's not suggesting that's inconsequential. But when we're thinking of the sort of the risk-benefit ratio and what we might do to address what appears to be over-prescribing of antibiotics for respiratory tract infection, it's important. It's worth noting that we can make reductions, and there are trade-offs with that. But nonetheless, the take-home message here really is that prescribing antibiotics doesn't really effectively prevent complications for following respiratory tract infection for most patients. NICE has weighed up the evidence and the clinical trials. So for something like acute cough, they point out that patient cohort, which I've sort of circled here in the sort of the pink box, is that patient cohort who is at higher risk of complications. So if we're thinking here of children, it's going to be young children born prematurely. For older patients, if they have comorbidities, so they're sort of guiding you to when you would need to consider either a backup prescription or an immediate antibiotic prescription, because those patients are at higher risk of complications. But for lots of other patient cohorts, antibiotics aren't going to prevent those complications. So just very briefly, considering the time of the evening, you've had a long day at work. I'm not going to go into any great detail about these studies and trials, but the StarWave trial, it's not a trial, sorry, but it was a study to develop and validate a clinical rule that would predict risk of hospitalization within 30 days for children who present with acute cough and respiratory tract infection in primary care. And what they found was that there were seven characteristics that are independently associated with hospital admission. And if you can calculate, you score for each, give those a score of 1 for each of those, you can calculate 3 risk strata of either very low risk of hospital admission, normal, or a high risk of hospital admission. And they suggest that if you could use that tool, you could identify the cohort of patients who are at very low risk, and you could consider using that as a strategy for a no antibiotic prescribing or a backup antibiotic prescribing strategy, depending on their score. So if you've not come across it, it's StarWave. It's a mnemonic, so it stands for a short duration of illness, temperature, age less than 2 years, some inter or subcostal recession, so more suited to a face-to-face consultation than a virtual one. Some wheeze and auscultation, asthma, and vomiting within the previous 24 hours. So a point for any of those. And so a score of 0 to 1 is you're very low. The child is at very low risk of a future admission, 1 in 320 risk of future admission, and you could consider a no antibiotic strategy. Normal risk score of 2 to 3, 1 in 70 risk of admission, so you could consider a no antibiotic or a backup antibiotic strategy, depending on what else is relevant. And obviously those patients who are at higher scores or higher risk, you'd want to prescribe an immediate antibiotic with either next day or same day follow-up. So this might address some of that anxiety that clinicians have about missing or a patient going on to deteriorate, if they don't prescribe antibiotics. So knowing that antibiotics aren't particularly protective for starters, but also using a score like this might be helpful when considering is a no antibiotic strategy suitable or a backup antibiotic strategy suitable for your patient. And then very briefly, the Arctic PC trial, fantastic trial, which was looking at the, it was a randomized double-blind placebo-controlled trial for children who were between 6 months and 12 years old with an uncomplicated, so that's the important bit, uncomplicated non-pneumonic lower respiratory tract infection, amoxicillin or placebo. They had 5 different pre-specified clinical subgroups, which included patients with chest signs who were feverish. The physician had rated them unwell. They had sputum or chest rattle or shortness of breath. And even within those pre-specified clinical subgroups, antibiotics, there was no difference in outcome between placebo and amoxicillin. So again, they suggest that antibiotics and amoxicillin is unlikely to be clinically effective in an uncomplicated chest infection. And unless you're suspecting pneumonia, consider providing safety net advice, but not antibiotics for children presenting with chest infections. So, bit of a mad rush through all of that, but my view is antibiotics are associated with quite a lot of harm, maybe some of that harm that we haven't necessarily considered or been aware of up to this point. Respiratory tract infections do last for quite a long period of time, and it's important to communicate that to caregivers. Most children who have a respiratory tract infection, acute respiratory tract infection and cough, are actually very low risk for deterioration. But if you use star wave, that might help identify the cohort who aren't at that very low risk or who are. Antibiotics don't really help for an uncomplicated chest infection. So thinking about that, how do we take that information forward and build that into our sort of approach to managing these infections in primary care? So what's the impact of communication? How do we have a successful consultation with our parents and caregivers? So there's been a recent update to a systematic review, the Cochrane database systematic review, and this was looking at the sort of impact of different antibiotic prescribing strategies on respiratory tract infections. Both adults and children are included in these studies, and they looked at a couple of different outcomes. So what was, so comparing a no antibiotic strategy, a delayed or a backup antibiotic prescribing strategy, or an immediate antibiotic prescribing strategy. And they looked to see what was the impact on antibiotic use, patient satisfaction, clinical outcomes, duration of clinical outcomes, reconsultation rate. And when you compare delayed antibiotics to no antibiotics, or you compare immediate antibiotics to delayed antibiotics, by and large, there's very little difference. If you don't give anybody antibiotics to start with at the index consultation, then obviously the antibiotic consumption is lower than if you'd given them a backup or an immediate antibiotic prescription. Patients tend to be most satisfied with an immediate antibiotic, but there's actually no statistically significant difference between immediate and backup antibiotic prescribing for satisfaction. There's mostly no difference in clinical outcomes. There's mostly no difference in duration of symptoms. And importantly, when we're thinking about backup prescribing strategies, there's no difference between immediate and backup, no difference in reconsultation between immediate and backup antibiotic prescriptions. So what would help to have that no antibiotic strategy, if that's suitable for your patient, and how do you have that conversation? So the key things from the evidence seems to be having a satisfactory consultation, having an effective consultation. Critically important to promote those self-care and safety netting resources for caregivers, patient information leaflets and other resources, which I'll briefly cover at the end. But also really importantly, from a good clinical practice perspective, from a medical legal perspective, as well as coding the provision of self-care and safety netting advice. So if you've given a leaflet, coding that. If you've advised, self-care, coding that. There are codes that capture those. And it's important because when we think of all the studies that I've been presenting, they're based on coding data. They're retrospective studies mostly based on coding data. If we haven't got the coding data, it's very difficult to work out if our interventions, if the outcomes are safe, if the outcomes are good. So a plea really for more coding. We know that only about something like 40% of antibiotic prescriptions don't have a diagnostic code associated with them. So focusing in on communication. So this is a Dutch study that was looking at the management of lower respiratory tract infection in adults and seeing the impact of CRP machines on that, CRP testing. Ignore all of that. What's really striking about this study is they gave the GPs enhanced communication skills, and then the GPs used those during their consultations, and it didn't increase consultation time. They also used it summer and winter, so there was good fidelity. They once they'd learned the skills, they used them consistently. And a striking reduction in antibiotic prescribing. So compared to usual care, where about 67% of these patients got an antibiotic prescription, with the communication skills and a patient information leaflet, they halved that. If you can add in CRP and stuff, then you lower it even more. But I know that's not widely available in primary care. But just with enhanced communication skills, we can reduce antibiotic prescribing. And the key really is having that successful consultation. So thinking back to the qualitative research that tells us a little bit about why parents and carers are seeking a healthcare consultation in the first place. So this chest mnemonic was developed by GPs. It's evidence-based, and you may well be familiar with it already if you've been to a Target training session. There's more information about it on the Target website, lots more resource to support this, but it's a mnemonic to help prompt the stages of the discussion. So asking specifically, what are you most worried about? What are you concerned about today? And discussing the history in the examination. So they advise doing a sort of no problem commentary, assuming you're not finding problems with your examination. But yeah, your heart rate is normal, your temperature isn't raised, the eardrum looks okay, whatever that might be. Asking specifically what their expectations are. So how do you think I could most help you today? Or what do you think about antibiotics? Understanding where they're coming from and their desire or not potentially for antibiotics could be quite helpful in structuring your approach to the consultation. Providing an explanation for those symptoms that aren't serious, so whether that's phlegm, sneezing, coughing, whatever those might be, to help keep your lungs clear. Now, they suggest covering that in and then telling them how long the infection, the condition is likely to last. So cough is going to take at least 3 weeks to clear. You're going to be coughing potentially for up to 3 weeks. That doesn't mean things aren't getting better. A lot to cover in that. So they suggest using the patient information leaflet to cover the timeline, the shortcomings of antibiotics, the self-care, the safety netting advice. But putting all of that together is helpful for a successful consultation. And of course, you have to, as you know way better than I do, but caregivers, people who are turning up may not have had sleep if they've got a poorly child. They're not necessarily going to remember everything you've said. They may be anxious and not listening. There's lots of reasons. So using safety netting, self-care resources are really, really powerful to help the consultation, to increase recall satisfaction, and also their ability to self-care in the future. You'll know that you'll have your own preferred way of using these leaflets, whether you send them electronically or whether you've got them printed out or whatever it might be. So again, trying to make that leaflet personal and using it interactively during the consultation has been shown to be helpful. Not so sure, Conor. There's going to be some patients who you're not happy with the no antibiotic strategy, but you might consider a backup prescribing strategy. So what about that? What do we know about backup antibiotic prescribing? So as I've mentioned before, patients are still satisfied with the backup prescription approach. No significant difference between that and an immediate antibiotic prescription. It does reduce the antibiotic consumption. Now this is based on old data when back in the day, if you can remember, when we had paper prescriptions and there was different ways of limiting access to that prescription. You either held it back at reception, you asked somebody to phone, you future dated it, whatever it might be. It's less easy now with electronic prescription service, of course, but what the data for backup prescribing shows is that it does reduce antibiotic consumption compared to an immediate prescription. It's useful for you if you don't entirely know whether an immediate antibiotic is needed, or it's bank holiday weekend coming up and you're not sure what their access to healthcare might be. Importantly, there's no difference in adverse events compared to immediate prescriptions, and there's no difference in reconsultation rates compared to immediate antibiotics. And this forest plot again just confirms that as well. Really importantly, I think, if you're going down the backup route, so survey work we did in the Midlands and the Southeast with primary care clinicians was that they tended to give an immediate antibiotic prescription, but then advise the patient or the caregiver verbally not to take it unless things didn't get better in a couple of days. It would be really good to code that. There are SNOMED codes for backup antibiotic prescribing, so really, really good to help with audit from a medical legal perspective. And just good clinical practice, the code and the backup prescription. Nope, not happy, Conor. And of course, there is going to be patient cohorts who need immediate antibiotics. None of this webinar is intended to say don't prescribe antibiotics to children. There's obviously children and adults as well who need immediate antibiotic prescriptions. And that's entirely appropriate. And all I can say really on that is to follow your local guidelines for choice and duration. So interestingly, this is data for 5-day duration amoxicillin prescriptions on FP10 in England. So this is the 500 milligram capsule, so not entirely relevant to a pediatric cohort, obviously, but it might be a marker to what peak durations people tend to prescribe in primary care. And it's really good. You can see the green bars are the proportion of 5-day courses, and they have been increasing over time because you'll probably be aware there's been a focus on this in the last few years. So we're up to around about 66% in the most recent data for England. We'd like to get to, maybe 70, 75% potentially, recognizing that it will never get to 100% and it wouldn't be appropriate to do so. But the take-home message really is that, for a lot of these respiratory tract infections, NICE recommends a duration of usually 5 days. So if we're giving 7 days or longer, it's not necessarily following what NICE recommends. And for children, but you might get pushback from patients or parents. Oh, no, I've always get 7 days. Why have you only given me 5 days? 5 days doesn't work for me. Well, actually, there's really good evidence for even, quite severe infections like community-acquired pneumonia, where there's multiple studies in children that show non-inferiority with shorter courses of 3 to 5 days. So 7 days is kind of out the window, I'm going to suggest, especially for children. Lots of trial evidence to show that. And NICE have recently updated their guidance for community-acquired pneumonia for children between 3 months and 11 years with non-severe community-acquired pneumonia who don't have complications or an underlying disease, offer a 3-day course of antibiotics. So NICE is moving with the evidence, so that's really good to see. So coming back to some of the inconvenient things I mentioned about prescribing and reconsultation rates. So coming back to this study. So again, this is the study where they stratified the GP practices first by their age, sex, comorbidity distribution, so that it essentially evens out high prescribing practices where you have a greater proportion of comorbid patients, for example. So they kind of level the playing field first with the GP practices, and then they stratified by prescribing for respiratory tract infection consultations. So just as a reminder, they found no difference between the highest prescribing GP practices and the lowest prescribing practices in risk of hospitalization within 6 days of that index consultation. But they did see an increase in odds of reconsultation. As I mentioned earlier on, that kind of flies against what we also previous studies have shown where prescribing leads to reconsultation. So obviously this is a large population cohort study, 9 million patients. So we don't know what the individual circumstances are at these lower prescribing practices. And what the authors suggest is that there's lots of things that impact reconsultation behavior. So prior consultation rates, prior antibiotics satisfaction, knowledge about antibiotics, and so on, and their benefits for respiratory tract infections. So although that odds ratio is higher for the lowest prescribing practices, when you look at the absolute difference between the reconsultation rate for the highest GP prescribing practices and the lowest prescribing practices, it was only 2.3% as an absolute difference. So not a massive difference, but when you express it as an odds ratio, it goes higher. And that was overall for children less than, less than 5, odds ratio of 1.13 for reconsultation. So what happens when you give people antibiotics? Do they still reconsult? Well, this study kind of suggests that they do. So this is another really nice study published last year. Again, English primary care, UK primary care, I can't remember exactly. And it was looking at what they call within episode repeat prescribing. So this was looking at patients who consulted in primary care for a respiratory tract infection, either upper or lower, received an antibiotic, went away, but then reconsulted within 28 days of that index consultation. And what they found was that for adults, depending on whether it was upper or lower, so I think for upper respiratory tract infections, they had about a 10% reconsultation, 10%, and lower respiratory tract infection was about 20%. For children, it didn't matter whether it was upper or lower, it was around about 10% of children reconsulted within 28 days, with a median of about 10 days. So even when you give them antibiotics on that index consultation, a proportion are going to reconsult. Now, what they suggest in this study is that it's really, first of all, important to sort of make clear that when you prescribe, you're prescribing an evidence-based antibiotic course. We know that this antibiotic will treat your infection. So if things aren't, improving, that doesn't. That course is adequate from a microbiological perspective to achieve cure. And maybe it's, we used to give you 7 days for this. Now we give 5. We know that is just as good and is safer than 7 days. But also knowing what we know about the symptomatic benefit that antibiotics deliver, the duration of symptoms, the natural history of the illness, it's worth reminding parents and carers that the symptoms might last longer than the antibiotic course, especially if we're giving antibiotics for 5 days now, hopefully. But they might have symptoms for 7 days. They might have acute cough and coughing for 3 weeks. It's important to stress that, you know, even if their symptoms persist, that doesn't mean they need to come back and see you unless there's a red flag, unless there's some deterioration. Or they've got some particular concerns. So that's a useful message, I think, that may well impact on reconsultation rates. So I've just got, I can't remember how much I've got. I'm just going to fly through this next bit because I'm sure you're well aware of these. But in terms of supporting our patients, you know, with self-care advice, safety netting advice, which is really, really critical if we are doing the no antibiotic or the backup antibiotic prescribing strategy, and even when we give immediate antibiotics as well. It's important not to dismiss the impact of verbal safety netting advice, written safety netting advice, and useful websites, the reliable websites. So those tend to be, you know, the evidence quality isn't brilliant, but they tend to point to being greater than the sum of their parts. So if we can give people verbal advice, written advice, signpost them to a useful website, we have high levels of satisfaction. We may be reducing reconsultation, and we may reduce antibiotic prescribing as well. So important not suggesting anyone does this, but important not to dismiss or overlook those. So obviously the target resources are absolutely fantastic. This is the Treating Your Infection leaflet, which is suitable for children. Quite a lot of words on it, but it is available in multiple different languages. It's got all the bits we need in terms of self-care, safety netting, and so on. So absolutely fantastic resource, which I'm sure you use on a very regular basis. There's a more pictorial version, which might suit different patient cohorts. Then you can send those resources electronically. You don't need me to tell you this because you know how to do this and you do it every day, but you can send them out via AccuRx or through EMIS System 1 as well, I believe. So, you know, you can get this information to patients in a suitable format for them. The Children with Cough leaflet is also really nice, produced by the University of Bristol, and it's really specific for parents of younger children, I guess parents and carers of younger children, you know, and it goes into why they're coughing, why they might have disturbed sleep, feverish, off their food, eating, drinking less. And then the other side of the leaflet is got the sort of the when you should be seeking care, you know, there's sort of the red flags and stuff. So really, really nice leaflet that's really very tailored to the patient cohort we're thinking of here. And then the Healthier Together website is a fantastic website resource both for you as healthcare professionals, but also parents and carers and caregivers and older children as well. It doesn't just cover infection. There's lots of fantastic content on there, as you can see the different areas. But thinking about it from a sort of specific respiratory tract infection, it's got really nice information sheets on bronchiolitis, coughs and colds, otitis media, that sort of thing. There's videos that parents you can signpost people to watch. You can send the information to their mobile and stuff. So a fantastic resource that we really encourage people to make use of. So summing up now, Emily, you'll be relieved. So I think the take-home messages for me is that the demand for antibiotics seems to be very high. It's higher perhaps now, or certainly the prescribing is higher now than it has been 5, 6, 7 years ago. So we need to think about ways of managing that demand. What's driving it? It's probably anxiety, but how do we manage those consultations? And I think the key actions are to have successful or effective consultations that address those concerns and expectations, being really upfront and understanding where the parent, the caregiver is coming from, what their concerns are, what their expectations are. I think it's really important to communicate how long these things normally last. They won't necessarily clear up quickly. 9 out of 10 children are going to take at least a week before they feel better. Or 3 weeks, whatever it might be. Supporting the no antibiotic strategy, the backup prescribing strategies, and indeed the immediate prescribing strategy with verbal and written safety netting advice, signposting them to useful information that could be useful to them, both for managing it now, but also in the future. And also thinking of all the different people who are prescribing antibiotics across primary care. So making sure that everyone in the practice or the whole team is taking a similar approach. So patient cohorts are getting the same messages, irrespective of who they're seeing at the practice. So that was my last slide, Emily. I'll pause there, I think. Am I going on to the next slide? Sorry, Emily, you'll have to prompt me. I've forgotten.
I can't seem to. Sorry, there we go. Yes, thank you so much, Connor. That was excellent. Yes, please, next slide. So just a reminder for everybody to please complete the feedback survey. We'll put this up again at the end of the chat if that's all right. And Camilla will be sending this information out to everybody at the end of the chat by email at the end of the chat as well. Also to remind you that we do have 2 more webinars coming up over the next number of months. So please sign up for those if you're interested. Next slide, please, Connor. Okay, so now we're going to go into the panel discussion. Again, thank you so much, Connor. That was such an interesting presentation. We really appreciate you sharing with us. Now we're going to pose some questions to the panelists that we've received during the chat. We've had many, and we're going to try to get through as many as we can over the next 15 minutes or so. So Graham, I'd like to start with you. So we had a number of questions around delayed prescribing come through. Some of the questions were about making sure that they're providing delayed prescribing prescriptions in the right way, making sure patients start them when they should and things. Also, about whether or not it's better to maybe have a patient return and reconsult instead of giving a delayed prescription. And I just really would like to see if you could just talk a little bit more to that and maybe provide us with some thoughts in your experience.
Of course. So it's been a much asked question, and I have tried to answer some of them in the chat. But I think the take home is that there is no right or wrong way here, and I don't think you should be following a specific script, because each child will need their own individual assessment, both in terms of their clinical presentation, in terms of which respiratory infection is it, the severity, the age of the child. And people have been saying, what if they had a previous severe chest infection requiring admission, and then particularly exploring the parental concerns and expectations. So there's different reasons why you may do it as well. So the parent insists that they have antibiotics, and you're very clear in your mind that they don't need it. Would you consider a delayed prescription then? Possibly, but it wouldn't seem to be the right thing. You think you'd be offering a clinical review. But if you have, for example, an otitis media that's bilateral, a feverish child, you may try something like a Tygo to manage their pain. But if you're seeing them on a Friday, it probably would not be unreasonable to consider starting antibiotics 2 days later. So in that case, you may offer a prescription. The question was, how do you do a delayed prescription? So you can either issue it there and then with today's date on, or you may put a deferred date, typically 1 to 2 days on that prescription. And then it depends whether you're going to send that electronically or paper, depending on how quickly you think the parents may be inclined to go and cash that prescription in. But it's all about, I think, having a clear understanding and agreement between you and the parent.
Thank you, Graham. That's really useful. Alicia, a question for you. So we've had a number of people talking about the issue of patients maybe living in deprived areas, often being maybe more anxious. Also, they're less able to or struggling to buy some of the self-care things that might be suggested to them. Just wondering if you could speak to that at all, and if you have any thoughts on that one, those questions.
Absolutely. Thank you for whoever has asked the question. It is definitely a tricky one. So we do know that there is more prescribing in people who are coming from areas of deprivation, and that's measured by the index of multiple deprivation. I've put in the chat a link to our SBAR report from last year. Or this year's report is coming up in just a few years, in just a few weeks. And I've put page 77. We have a clear graph that shows that the most deprived people are, the more they receive antibiotics, and specifically broad spectrum antibiotics. So this is probably multifactorial. There is how much of this is related to infections that people are more at risk to, communications with providers, and lots of other things come into play. So at the moment, we do have some descriptive data, but I haven't seen enough deep dives to be able to say what is a cause and what can be worked on. So my request and my advice is really to look more into this link to describe it better so that we can design interventions for this.
Thanks. It's a good request, Alicia. Thank you for that. Sanjay, question for you. This is an interesting one that came through. It's about schools driving attendance at GP surgeries because they're asking parents to provide photos sometimes of antibiotics to show that they're actually ill. I didn't know about this, so I was wondering if you could speak to it a little bit and maybe provide some thoughts around this area.
Yeah, I think this is a really important observation. And I think often many of us have seen it with nurseries that can drive a lot of attendance into primary care. And I think one of the issues we all know, is that we work in a very fragmented system. And whilst we work in a fragmented system, we offer different advice at different points of it, and that's really harmful and damaging for parents and their confidence. So much of the fabulous presentation Conor's given has spoken about confidence or lack of in parents. And although we try and build it up, we then erode it when we give a different opinion in a pharmacy compared to a GP practice compared to in an emergency department. And schools are part of that journey as well. So I think firstly we need to get our own house in order in terms of the urgent care pathway and any platform we have where we can be more consistent in what we say to parents, how we reassure them, how that aligns with the information that's public facing is really important. That's what we try to do with Healthier Together. But I think we also need to reach into schools, and Alicia's on the call. She works part of her time with UKHSA, and they do some really good work with the Ambassadors program that goes into schools. We have World Antimicrobial AMR Awareness Week coming up next month. And I think we need to be reaching out to schools, because that inconsistency, with people who've spoken about the cost of living crisis, then going to your GP when you've already struggling with household bills and you're trying to work, is just hugely damaging. So in Wessex, we work very closely with our schools so that we provide them with clear information about when a child should and shouldn't be going to school. And that then hopefully means that they send less children to GPs when actually that child should be in school receiving an education.
Thanks, Sanjay. Next question is for Graham, and this is one that we've had in other webinars as well, but it's about patients reconsulting elsewhere. So you might not give an antibiotic, maybe they go somewhere else, and maybe they'll get an antibiotic there, maybe they won't. But as a GP, how do you deal with that, especially when you're looking at delayed or non-prescribing options?
Well, I think it can feel very frustrating where, I think if you feel you spent a lot of time with a parent, you've done a very thorough examination, and then you get contact that evening they went to an online service or out-of-hours service and received a prescription. There isn't any way of stopping it happening, of course. I think it's worth just acknowledging that people do have different thresholds for prescribing. And I think overall within primary care, we are probably far better, not perfect, but far better than, say, an out-of-hours service at probably not resorting to an antibiotic. I think probably the reason we're all on this call tonight is because there's a feeling that, give a patient a prescription or the child of a parent a prescription and they will go away and they're no longer your problem. But I honestly don't think that's the case. As Conor has mentioned, you'll increase reconsultation rates. As Sanjay said in the chat, you're more likely to do harm with side effects and increased resistance to the antibiotic next time they represent. So you can't change what other people will do. It won't always be because you haven't done a good job or you've got it wrong. I think if you were concerned that you missed an infection, for example, I would personally, I tend to pick up the phone to the parents and say, "Oh, how did things go? What were your concerns, and how is the child now?" It might just reassure you that you've not missed anything, but it probably would help a bit of education for the parents as that sort of opportunity, perhaps when a little bit of the tension has gone because the child has received a treatment, be it right or wrong.
Thank you for that, Graham. That's really useful. So Alicia, I'm going to ask you a question. So we had a one come in about the RSV vaccine and how that might influence bronchiolitis, and then in turn how that might impact antibiotic prescribing for an individual, perhaps for a population. So I was just wondering if you wanted to speak to that question a little bit.
Yes, thank you, Emily. So it's really, really exciting to see this new development with the RSV vaccine. And so not just for infants where we see the highest mortality and the highest effects, but also we do expect that this will spread as it has, for example, for the pneumococcal conjugate vaccine across different generations. So that's really good news in terms of the infectious diseases world. We have to have a note of caution because infections keep us on our toes, and sometimes the disappearance of one, if I can hope for a disappearance, but at least a decrease, sometimes leads to a void and then new things happen. So let's keep our eyes open. But I do expect that we will see less RSV once there is enough uptake. We're not yet there, so probably in the next couple of years or so. And so this will lead to first less prescribing for children who had probably a viral infection, and then a clinician perhaps wasn't sure, thought they had the bacterial infection, were prescribed an antibiotic. But also for children who had a viral infection to start with RSV, and then went on several weeks later or even a couple of weeks later to develop a bacterial infection. So overall, I think this RSV vaccine is just great news for antimicrobial prescribing in the sense that it will help us prescribe less antibiotics that are not necessary.
That's great. Thank you, Alicia. Sanjay, I had one more for you here. So this is about penicillin allergy in children, and children having a rash because they've been given amoxicillin. Parents are worried it might be an allergy, but it might also be a viral rash. Is there any way of determining the difference between these? And just if you have any other thoughts on maybe the link between allergies and the antibiotic prescriptions.
Yeah, I think this is a really important question. And the reason it's so important is that out of all age groups, children are the most inappropriately labelled with a penicillin allergy because they're so much more likely to have a viral infection and to then get what looks like an allergic rash or a viral rash secondary to their infection. I think there is tangible harm, unfortunately, from incorrectly applied penicillin allergy labels because they're more likely to then be given a broad spectrum antibiotic and thus either but then potentially have an increased risk of AMR and worse mortality and morbidity outcomes long term. I put some answers in the chat about this in terms of the timing of the onset of symptoms, within an hour or not. Often it's day 2 or 3 of an antibiotic and they develop a rash. And it's much harder to take a label away than put it on in the first place. And so I really encourage people to look at the chat and look at resources that are available. We've got some things on the Healthier Together website for prescribers that will help them make that distinction. But a lot of it is to do with the timing of the onset of the rash.
Fantastic. Thanks, Sanjay. And Connor, I'm not going to give you a reprieve. I do have one question for you. We have a question about an ICB that's keen to see StarWave on their clinical systems, but having some challenges with this. Do you have any suggestions for that? And I don't know what's happening in the ICBs in your area, but maybe you can speak to that question a bit.
Yeah, so I didn't mention it, but you're obviously aware that StarWave isn't sort of enshrined in the NICE guideline for management of acute cough in children and stuff. So as a result, it's not in clinical templates, for example, Arden's. So they do have the StarWave calculator in I might not be describing it exactly right, but they have a section for clinical tools or calculators, I think, and they've got the star wave calculation. You can fill out the star wave scoring in that, but it's not built into clinical templates. We have asked NICE if they would look at the star wave study again, but because I think it's not a prospective randomized controlled trial, it doesn't meet their sort of evidence criteria, I think, for the guidelines. I think I've got that right. So I think we just have to keep petitioning the suppliers to say this is a useful tool. Could you please make it available to people in the clinical systems?
Thanks, Conor. And we have 1 minute left. I'm wondering, Alicia, would you like to come back on a point around the harms of prescribing that was raised?
Yes, thank you, Emily. I think that's really important because I've seen several questions that alluded to that, perhaps indirectly. I think it's really important to remember that when we prescribe an antibiotic, it's not something that we do basically for free. So there are harms that come with antibiotics, not just the potential immediate harms such as allergies, gastro upset or these kind of things, but there's also potentially some longer term issues. I've posted a link to a really good article that is quite recent in the chat, and this shows an association between receiving several antibiotics in the first 2 years of life and developing chronic conditions. So we're talking about things like asthma, atopy, cardiovascular problems, allergies. And there's also a very good study in the Lancet Respiratory Disease from 2020, and obviously it did not get the coverage that it deserved, basically showing that in some areas in Canada where there was a decrease in antimicrobial prescribing because of a national stewardship initiative, there actually has been less new cases of asthma. And they are now working on the evidence that could link those two statements. And we think that this is related to microbiota, so how your normal bacterial flora is actually changed by antibiotics. So I want to remind everyone that some of the side effects or some of the things that we are giving to a patient with those antibiotics are not necessarily immediately apparent, and that's why it's really important to reserve antibiotics only in cases where they're absolutely needed.
Thank you for that response, Alicia. And, unfortunately, we'll have to end here because we're a bit over. But I just want to say a massive, massive thank you to you, Conor, for sharing your presentation with us, to all of the panelists who fielded the questions. We didn't nearly get to all of the questions in the chat. We will publish the Q&A at the end, so we'll try to address your question when that's published. But a big thank you as well to everybody who's attended, posed questions, and listened so well. So thank you all, and I hope you have a good evening.
Thanks, everyone.
Thanks all.
Thank you.